I'll go ahead with the basics and the theory part a bit, and then I will go into the little bit of a case studies. So yeah, as I mentioned, today is World Thyroid Day, and this year's theme is Thyroid Health, Nurturing Well-Being. So yeah, so nurturing well-being is very important, especially our congenital hypothyroid children. They need to be, the thyroid hormone is very important for growth, development, brain development, IQ, and skin, abdomen, everything. So it is very important that we know about this topic in detail. So this is an overview of what I'll be talking about. So I'll just take you step by step. And as we get into it, you can understand more and more about the disease. So a little bit about the embryology. So we need, if you're talking about hypothyroidism, we need to know about the thyroid gland because that is very important. We need to know how it's developed, what is the embryology of the thyroid gland. So the first endocrine structure to ever appear in the thyroid, during the development is the thyroid gland. It originates between the first and the second pharyngeal pouches near the base of the tongue. The thyroid arises from the pharyngeal pouches, which is composed of the endoderm. The thyroid development usually begins as a diverticular outgrowth. And in the primitive pharynx, the diverticulum then descends inferiorly to reach its final destination. So the thyroid is usually located inferior to the thyroid cartilage, and during its descent, the thyroid connects to the tongue. So we have the thyroglossal duct. So if there is a remnant of the thyroglossal duct, it can lead to a thyroglossal cyst or a fistula and can get infected. And this is what happens. So usually the thyroid gland, it is usually at the back of the tongue called the foramen cecum, and it descends down to go inferior to the thyroid cartilage. And the entire histogenesis is completed by 10-week gestation. And by 12 weeks itself, the thyroid hormones, that is T3 and T4 appear, and TSH appears by 10 to 12 weeks. And usually in the fetus independently does not produce thyroid hormones till mid-gestation. What is important is the maternal transfer. So the maternal transfer of thyroid hormones is very important for fetal brain growth. And this maternal hormones is taken up by the astrocytes in the brain, and this is important for the development of the neocortex or the brain. So this is what I mentioned. So we have the foramen cecum here at the back of the tongue, and during embryogenesis, the entire thyroid gland migrates. So this is the migratory path. It migrates to go completely down and become the thyroid lobe. So the thyroid consists of two lobes, the left lobe, the right lobe, and the isthmus. So it comes and lies underneath the cartilage. So there are some genes which are very important for thyroid development. The most important is thyroid transcription factor 1 and thyroid transcription factor 2. So these are the two most important. Apart from that, we also have PAX8, GLIS3, which are not very important, but they can cause congenital hypothyroidism associated with multiple other anomalies. So if you have a child with congenital hypothyroidism, we can do a genetic test. These genes might be detected. So coming to a bit about the hypothalamic-pituitary thyroid axis. So this axis is very important. As we all know, the TSH is produced by the anterior pituitary. And how is it produced by the anterior pituitary? It is produced by the positive feedback from thyrotropin releasing hormone from the hypothalamus. So the hypothalamus produces TRH, which then stimulates release of TSH from the pituitary. And this TSH is the chief player in thyroid gland function as well as morphology. So once the TRH stimulates the TSH is produced by the pituitary. The TSH then acts on the thyroid gland and stimulates the release of T3, which is the active thyroid hormone, and T4. So the active thyroid hormone is T3, but most of the thyroid hormone that is produced comes in the T4 form. The T4 form then undergoes peripheral conversion and becomes the active T3. This active T3 then acts in the peripheral tissues and provides all the tissue action. Meanwhile, apart from all this, we also have a negative feedback. That means, suppose the thyroid gland produces excess of T3 and T4. The thyroid gland produces a negative feedback to the brain telling that the thyroid hormones are high, and the negative feedback results in decrease in the TRH, decrease in the TSH, and as a result, the thyroid hormones also is reduced. So there's a positive feedback as well as a negative feedback. So a bit about the neonatal thyroid physiology. As we all know, a newborn baby in the first 24 to 48 hours, there is a huge peak in the TSH. So the TSH peaks, especially within 30 minutes after birth, it peaks at 24 hours and slowly over 2 to 5 days, it normalizes. Once the TSH peak happens, that is when the rise in T4 or the T4 peak also happens. So they say that the TSH peak is due to stress during labor, exposure to very cold hypothermia, that is inside the womb, the baby is in a warm environment without any stress. But in the extrauterine environment, because of hypothermia stress, what happens? The TSH release happens. So when we are doing a newborn screening, either we do a cord blood, that is with the cord blood sample, or we do it after 40 to 72 hours. So the cord blood sample is not affected by the TSH surge. Postnatal samples, if they're collected after 48 hours, there's no issues. But if they're collected before 48 hours, they can have high false positive rates. So the cutoffs will be different if they're collected earlier. This is because of the TSH surge. So coming to a bit about the thyroid hormone synthesis. So in this picture on the left-hand side, you can see the entire thyroid hormone synthesis. So how is it synthesized? So for thyroid hormone synthesis, we need a thing called iodine. Iodine is very important. So iodine enters through the sodium iodide symporter. This is part one. Once the iodine enters, iodide gets oxidized along with tyrosine. It gets oxidized. Okay. After it gets oxidized with the help of hydrogen peroxide. Once it gets oxidized, it gets organified. That's called organification. So iodine gets organified and it forms two components called monoiodothyronine and diiodothyronine. So these monoiodothyronine and diiodothyronine further undergo coupling. So they couple to form, as I mentioned, active form, which is T3, and the other thyroxine, which is T4. And then at the same time, there is thyroglobulin, which is the transporter of thyroid hormones. Thyroglobulin gets taken up into the cell, that is endocytosis. And then thyroglobulin releases the thyroid hormones, that is T4 and T3, into the circulation. Once it's released into the circulation, it acts on the different peripheral tissues to cause its action. The remaining of the thyroid glands, that is which are in excess, they are not wasted. They are taken back into the thyroid hormones and they are deiodinased. So this is called deiodination. With the help of deiodinase enzyme, they get deiodinased along to form again MIT and DIT, which again releases the iodine and then it goes back again to the cycle. So it is a cycle. So a little bit about the action of thyroid hormones. So as I mentioned, thyroid hormone is very important. It has multiple actions, especially in the first 3 years for newborn brain development, as I mentioned. So in the heart, it has chronotropic, inotropic action. In the adipose tissue, it stimulates lipolysis, so catabolic action. So if a child is hypothyroid, does not have thyroid hormones, there is a tendency to gain weight because thyroid hormone is useful for lipolysis. Thyroid hormone is also causes increased protein breakdown. In that way, it is catabolic. It helps in bone development. So thyroid hormone is also very important for growth and skeletal development. So a child with long-standing hypothyroidism tends to be short and has a poor growth. Coming to development, as I mentioned, which is very important, it promotes normal brain development. In the gut, it increases the rate of carbohydrate absorption. It helps in metabolic. It has a metabolic function, and it is very important for basal metabolic rate and it's required for metabolism. So it stimulates oxygen consumption by the metabolically active tissues, and it increases the basal metabolic rate. So a child with chronic hypothyroidism will have a low metabolic rate, will be it will have a history of weight gain, will also have a history of not gaining height, low IQ. These are all the symptoms that a child will come with. That is an older child. So coming to a bit about congenital hypothyroidism, it is one of the leading causes of preventable mental and growth retardation, especially in the underdeveloped and developing countries like India, where only recently we have been doing routine newborn screening, and that also has been is going on only in the metro cities. In a few tier 2, tier 3 cities, they are not incorporating newborn screening as of yet. So that is very important that people get knowledge regarding newborn screening, because it is the most preventable cause of mental retardation. So as I mentioned, 28% of children with congenital hypothyroidism have intellectual disability. And before the advent of newborn screening, the incidence was 1:7,000, 1:10,000. With the newborn screening experience, the incidences, because it picks up, newborn screening has picked up more children with congenital hypothyroidism. So the true incidence they say is 1:3,000 to 1:4,000 live births. So coming to etiology of congenital hypothyroidism, so we can broadly classify into permanent forms, transient forms, and the lesser common forms. Among the permanent forms, we also have something called primary hypothyroidism, where the primary disease is within the thyroid itself, and central hypothyroidism or secondary hypothyroidism, where the problem is with the pituitary or the hypothalamus, that is the TSH-TRH problem, and that results in decrease in the thyroid hormones, resulting in hypothyroidism. So that is not a thyroid disease per se, but it indirectly, yes, it does cause central hypothyroidism. So permanent causes are usually any agenesis, dysgenesis of the thyroid, where the thyroid gland is not developed properly, or the thyroid gland is not in the proper position, like ectopic thyroid. A few cases of thyroid dyshomogenesis are also permanent, but a few can be transient as well, especially duox mutations. Coming to transient maternal thyroid antibodies. So if a mother is a known case of Graves' disease with maternal thyroid antibody positive, TRAB antibodies positive, the antibodies can pass through the placenta into the baby, resulting in baby having hypothyroidism. But this is usually transient, lasts for only a couple of months, and then once the antibodies go out of the system, it disappears. Iodine deficiency, maternal iodine deficiency, very common in hilly areas. That's why now we all use iodized salt. Maternal antithyroid medication. So again, as I mentioned, if the mother is a known case of Graves' disease and she's on antithyroid medications like propylthiouracil or methimazole, carbimazole, they can also have an effect on the baby's hypothyroid status. Excessive iodine exposure. So even iodine deficiency as well as iodine excess, especially if they use betadine during cesarean section, iodine excess, that can also result in decrease in the thyroid hormones in the baby, causing transient hypothyroidism. Okay, so the less common causes are central hypothyroidism and resistance to thyroid hormone at the TSH level. So as I mentioned, so the most common cause of the thyroid, is thyroid dysgenesis. Thyroid dysgenesis is seen in 1:2,500 to 1:4,000, of which we include agenesis, hypoplasia, ectopic. And then we have thyroid dyshomogenesis, which is seen in 1:30,000. Then we have transient hypothyroidism, 1:12,000, and central hypothyroidism, as I mentioned, also called as hypothalamic-pituitary hypothyroidism, seen in 1:80,000 or 1:1 lakh.